Well, good morning and welcome everybody to the Osher Center Grand Rounds. As you know, we've had a change in topic today. Unfortunately, our planned speaker had an illness, and so we had to make a change at the very last minute. And I'm so very grateful that my colleague and boss and the director of the Osher Center, Dr. Helene Langevin, stepped up and in the last minute took advantage of this timely topic and put together this presentation for today. So I think we're in for a real treat. And I don't think there's anyone more well qualified to deal with this issue. Dr. Langevin is a professor in residence here at the Harvard Medical School and director of the Osher Center, and she's also a professor in her old institution at the University of Vermont. And she has such a unique background and training that ranges from medicine, where she received a degree at McGill, and then she did some postdoctoral training in chemistry, biochemistry, and pharmacology, and then some in residency in internal medicine and some work in endocrinology, and somewhere in between all of that went to acupuncture school. And so she has such a range of tools to deal with the whole translational spectrum, but also the vision to see where some of these ideas fit in. And of course, many of you know her because she's one of the world authorities on connective tissue and mechanical forces, which I think brings us to the topic of today, which is around this idea of a new organ and the interstitium. So without any further delay, please join me in welcoming Dr. Helene Langevin.
Thank you, Peter. Well, this is going to be fun for me, and I hope fun for you. We're going to be talking about something that's been buzzing around the internet and the news in the last couple of weeks. I don't know, how many of you have heard of this new organ? Everybody, right? How is this possible, first of all? I was in Montreal visiting family over Easter, and I'm getting these emails like, have you seen this? What is this about? And so I thought I would just share with you some thoughts. Well, the first thing is, obviously, once I had a chance to, I, went back and read the original paper. But before reading the original paper, I read what was in the news. And so I'm just putting like a little smattering of, New York Times. Adara and I were just kibitzing earlier, trying to figure out what was the earliest source, what was the first news item that mentioned this, and we weren't quite able to trace it. It's not this one, it was before that, but it was probably around March 27th, 26th. Is this tissue a new organ? Maybe a conduit for cancer. So already there were some buzzwords, so you can see why the media picked this up. New foreign organ could be the biggest in your body. It gets bigger, right? And then this one. Everybody's freaking about this new organ, but it's probably not new. So you can see it's going through the cycle. And in this age of news amplification, when something gets sort of buzzy like this, you can see how it can it's like playing telephone, right? I mean, the news kind of just morphs over time. So what was the original source? Well, this is what it was. Scientific Reports, which is a reputable journal in the Nature publication group, peer-reviewed, good impact factor, and so this was published 27th of March, so you see, not long ago. And so there's no mention of a new organ anywhere in this paper, the entire paper, not just the title, but the paper. Structure and distribution of an unrecognized, however, interstitium in human tissues. So this interstitium is the key here to this whole thing. Why it got coined an organ, I will talk about that later. And I think that probably occurred during an interview that the authors did, with some news media. We don't quite sure which one. And then that's what really lit the news fire. But nevertheless, there was something here, even in this title right here, unrecognized interstitium. So first of all, what is interstitium? And secondly, why unrecognized until now in human tissue? So I'm going to just talk you through the paper as I went through it myself, looking at the figures and seeing what is it that they're reporting here. So the first thing that I will show you is what normally, if you look on the left-hand side, is this pointed work? Yes. So if you look at a histological section, I don't know how many of you are familiar with histology a little bit? Okay. So histology is something that is a technique that is very, very old. I mean, people have been doing histology for over a century. And what it is it's a technique that is, I have to mention, first of all, the authors of these papers are pathologists. So these are people who do histology for a living. If you have surgery and you go and you have a biopsy of anything, that's what happens. The little piece of tissue gets snipped. It doesn't matter if you have a biopsy of like a mole on your skin or during a colonoscopy, they'll take a little piece. And then they quickly, either they do one of two things. They freeze it, and then they freeze it, and then they cut it. And then what they do is they get sections. And then they look at that under the microscope. And usually what they do is they do some kind of stain. Because if you just look at the tissue under the microscope, you don't see, you just see mush. You have to stain it in order to be able to see something. And the other way that you can process the tissue is fix it. And what you do is you fix it in something usually called paraformaldehyde, which is a very strong, that cross-links everything. And it tries to, it's almost like it's a way to kill the tissue, but without killing it as much as possible, so that you can actually look at the tissue as though it was alive. And of course, it's not alive. So there are things that happen during either the freezing or the fixing that distorts things. So for centuries, people have been looking at pieces of tissue in sort of an imperfect state. Nobody has so far developed methods where you can look at a piece of tissue perfectly without killing it, right? But this is what this paper gets at, because they use actually what they call an in vivo technique, which I will show you later, where they claim that they were actually looking at the structure of the tissue live. And that's very important. So this is what it looks like when you look at a piece. This is a common bile duct, okay? So that's where they started their investigation. They were doing a surgery called a Whipple's procedure, where they go in and then they insert this little catheter into the common bile duct that goes to the liver. And normally, if you're trying to see if somebody has like cancer of the bile duct or something, what you would do is you would take a tiny little snip of the bile duct, and you would then process it, look at it under the microscope. And this is what you would see if you would looked at the histology. Again, this has now been, in this particular instance, I'm suspecting that I don't think they said, but I think this is fixed in formaldehyde. This is the mucosa, which is this kind of layer of cells that's right on top, and that's the lining. And then underneath is the interesting part. So this is what this pink stuff is. It's all collagen. And collagen is the main component of connective tissue. We're going to talk a lot about connective tissue throughout the whole talk, but connective tissue is really the stuff that is kind of connects everything. If you didn't have connective tissue, this little mucosa here would be floating around. It would not be attached to anything. It's the connective tissue that gives it its structure. And so this connective tissue here looks kind of like this kind of dense mass of stuff. It's not very well differentiated to the eye when you look at it. And what these little black arrows here point at are these little sort of white spaces. And anybody who's done histology knows that when you cut through a section, it doesn't matter how it's been fixed, there's what we call artifacts of cutting. And what that means is that if you're a really, really superb, splendid, technician who can cut, and use a knife, very, very sharp knife, to actually make very, very smooth sections through your tissue, the better you are, the less of these artifacts you have. But there's always some. And so these are like the little tears, right, literally in the tissue. And anybody who would look at a section like that and would look at those white spaces would conclude that they are just, that if you had been able to look at this tissue in the body, they would not have been there, right? That these were just artifacts of fixation and cutting, right? That this tissue was in fact solid. What the investigators and authors of the paper claim is that these little spaces are actually real, that they are something not only real but very important. And this is what they are proposing. I'm skipping a little bit ahead, but I'll talk you through all the arguments that they make to arrive at this picture. But this is the picture that they say actually exists in the body, that all of these little white things are not rips. There are actually cavities that are well defined, that are lined with, and this is where it gets a little fuzzy, they say they line with cells on one side, which is very strange. Why would that be? I don't know. But that the other side doesn't have cells. That just has kind of a direct interface between collagen and this, what they call fluid, interstitial fluid. Okay, so that's what they claim. And that this is kind of this vacuolated, what they call interstitium, which is in fact, what another good word would be a sponge, right? I mean, what this to me looks like a sponge, and it looks like inside this sponge you have fluid, and that the holes in the sponge have some kind of specialized structure to them, and that there are cells lining the whole of the sponge, and then these cells maybe are doing something. So far so good. The implication later on, and I'm going to I'll keep coming back to this theme, is that what happens when you squeeze a sponge? Right? Stuff comes out. If your sponge is full of liquid or soapy water or whatever, and you squeeze it, it'll go out. It'll come. So the idea is that because tissues are in the body subjected to mechanical forces, so what kind of forces? Well, in my lab, we study stretching a lot. Stretching, for example, or compression when you're pushing down, or even the kinds of forces that happen when you breathe, your lungs, expanding, and that pushes and squeezes the tissues, or even when in your gut, when you're peristalsis, right? When your gut is squeezing and moving the contents along. Your bladder, well, bladder when it fills and then when it empties. So these are all movements that happen because of some kind of either externally applied force or internally applied force via muscles, or externally applied force via some kind of intervention or treatment or whatever. That these forces would have an impact on this sponge, and that would make the fluid move around. Okay, so far so good? All right, so how did they get from here to here? Question. So let's go back to the common bile duct. So, okay, so this is the surgery, and they put this little catheter. This is the common bile duct. They have this technique, which is fantastic technique. It's called confocal laser microscopy. Confocal microscopy is not a new technique. It's been used now in the lab for decades. And it's a way to do what we call optical slices. So remember I was talking about when you do histology, you're doing manual slicing. You're literally slicing the tissue, cutting it. What the confocal microscope can do is it uses a laser, and if you, like the typical way that, I used to do confocal microscopy in my lab all the time, and you just take a piece of tissue, and instead of, you fix it or not, depending on how you want to look at it, and then you put it in this microscope. And then what happens is that you don't cut it. You just put the whole chunk there. You can put a chunk of tissue that can be as big as like 2 millimeters or more. And then what the microscope does is it literally optically slices through your tissue and gives you these beautiful renderings of different slices. And then you can actually put the whole thing together in 3 dimensions. It's really quite beautiful. What the new sort of advance that happened in recent years, not, of course, this paper is not the first paper I've done this, but it's a relatively new technique, is that you can now do this in vivo via a catheter. So you're not talking now about a big, enormous microscope that sits in the middle of a room. You're talking about a tiny little laser confocal microscope that sits at the tip of a catheter that you can then insert into things. So people are starting to use these laser confocal microscopes to do biopsies, right, in situ, but biopsies without taking the tissue out. You can do it 2 ways. You can either use the confocal laser to select where you're going to actually take your biopsy, That's one way to use it. Or you can just use it to take a picture of the tissue and not even biopsy it, just look at it. So it's a very interesting and nice technique. So what happens when you put your little catheter up the bile duct and you look? And so this is what they saw so imagine now that you're inside the bile duct and you're looking out through the wall, right? So the first thing you're going to see when I'm going to go back up to, imagine that you're sitting, your catheter is now sitting in this lumen, right? Inside this is the bile duct. And so if you were to sort of start to look at the wall of the first thing you're going to see is this, which is the mucosa itself. And then if you now start taking slices and going a little deeper and a little deeper and a little deeper, you're going to get into this stuff, right? Into this pink mess. When they got at about 60 microns, which is about here, right? Kind of below this thing. They started seeing this. So, okay, what does this look like? Well, it looks like this sort of honeycombed structure, right? Imagine you were able to look at a sponge using one of those microscopes. I think you could agree that you might see something like that. The one thing that they did before doing these procedures, they injected fluorescein, which is a substance that stains the tissues and that the tissues takes up, and they inject it intravenously. It's actually, benign that people use this kind of stuff all the time to highlight structures. And so what appears white is what the fluorescein is highlighting, and what appears dark is what is not highlighted by fluorescein. So in this case, they interpreted this as that what they're actually seeing here is the fluorescein in the holes of the sponge, and that the sponge itself would be dark, right? So this would be the sponge, the black, and the white would be the in-between. So going back to here, the white would be the spaces, and the dark would be the sponge itself, okay? So that was their interpretation. They wanted to make sure, though, that this is what actually was true, so they did the next nice step, which is they actually took the piece of tissue out, and they repeated this exact process, but now they took the tissue, they didn't cut it, but they used the same sort of laser microscope, confocal microscope, but outside of the body, on the piece of tissue that they could actually see. And they saw pretty much the same thing. You can see how there was white spaces, and then there's the dark, kind of spongy-like, structure. Then they said, okay, let's go a step further. Let's rinse out all the white, rinse out all the stain, flush it out. Now the stain would have only kind of adhered to the actual membranes themselves. Then they actually cut it using a microtome, and then they looked at it under standard fluorescent microscopy. And now what they see is the reverse image, so that you see the green stuff is the actual sponge now, because that's what has retained the stain. The fluorescein has washed out of the holes, and now the holes appear black. This is a very nice image. So you can see how it really corroborates what you saw before. And remember, this is what in the past people would have looked in this, and they would have concluded that these things were rips. Well, I think this, to my eye, these are not rips. This is real, right? So this is not an artifact. I think this is already a finding that is quite interesting. Okay, so what does this? So they wanted to go a step further, and they wanted to identify what is the composition of this sponge and what is in this, what kind of cells make it up. So the first thing they used what's called a classic stain called Masson trichrome, which stains for collagen. No surprise, that's what they found, collagen here. And when they have this, what they call this quick freezing spray method, which I'm not familiar with, but apparently it's a method to freeze the tissue quicker and faster and better, so that in their estimation, it preserved the structure. And in fact, you can see how you see where they put all these little asterisks. You start seeing all the little holes in the sponge. This would have been the tissue, like I showed you before, would have been using the same mesotrachome, but with the traditional fixation, you can see it's all collapsed. So you don't see, this is the same thing as this, but this is fixed differently. And so you can see how you don't see the holes here, and here you do. So that suggests that the holes had actually not been seen before because of the technique that was not allowing you to see them. The next thing they did is they did what's called immunohistochemistry. So it's the same thing as histology, but this time you are not using just a garden variety stain. You're using an antibody to highlight a specific protein that you want to label and you want to see. And so they just did a whole battery of different types of antibody stains, and they are only showing you the ones that were positive. These two, CD34 and D240. I'll come back to that later because that, I think, is important. Suffice it to say that what these are, both of these, especially the CD34, these are surface markers that allow you to tell what kind of cells are these are. So you have markers, for example, for different types of immune cells. Usually these are what we call antigens, and they sit on the surface of the cell, and they have something to do with the cell function. There are hundreds of these different types of cell markers. This CD34 is interesting for several different reasons. One is that it is traditionally thought to be a sort of a non-specific mesenchymal cell marker that has to do with stem cells. So stem cells, if you know a little bit about this, these are cells that are kind of like they can differentiate into other types of cells. And so, for example, a mesenchymal stem cell would be able to, under the right conditions and signals, differentiate into a fat cell, an adipocyte, a fibrocyte, a fibroblast or fibrocyte, or a muscle cell, or even bone, because there's a whole lineage of cells that all have to do with the musculoskeletal tissues. And there are stem cells that have this ability to differentiate. But CD34 is also interesting for other reasons. It has something to do with lymphocyte homing. So, for example, different types of immune cells are looking to attach themselves to another cell and recognize. And so there's an affinity of certain types of lymphocyte for this particular CD34 protein. Anyway, we'll get back to why this might be important. D240 is an interesting other protein that has to do with lymphatics. Now, this is where the paper gets a little bit less clear. Here, for the bile duct, remember this is all bile duct, right, so far? They show positive staining for CD34 and for D240. But later on, I'll show you, they looked at other tissues besides the bile duct, and they only found the CD34, not so it seems like the bile duct is the only place where they saw D240, but then they draw conclusions, that more generalized conclusions about lymphatics, even though they only saw the D240 staining for the bile duct, so I'm not really sure why that's about. But in any case, let's focus more on the CD34 because that's what their main findings were. The other thing that they say here, which I don't buy at all, is that the staining, based on this picture, which they show you, they're saying the staining is just on one side of these holes. Now, I don't know about you, but I cannot conclude that looking at this. You know, I mean, how would you say that this brown stuff is only on one side of this hole? Like, really? You know? So to me, that's not enough evidence to make that kind of claim. Even on this picture, you don't, you know. I think the important thing to recognize is that histological staining is never perfect. It's always, you know, the best that you can see. But if you had a cell, let's go back to, say if you had a hole like this and you have a cell that's lining this hole, if it was lining it all the way around and if it happened to stain for the CD34, you might see the CD34 staining here. You might not see it going around because maybe it's just gotten so thin the cell, or there's another cell there that's a little bit out of plane or something, that it might be there, you just don't see it. I don't think you can conclude based on that image that the staining is only one side. The thing is, they make a big deal about this, and they say that it's important that these cells are only on one side, because on the other side, you might not have any contact, any cellular interface between the liquid and the collagen, and they say that's unheard of, and that could be really important. I think that's really overreaching. The other evidence that they cite in order for this one side thing is that here, this is electron microscopy. So electron microscopy is a way to, they took the same biopsy, and then instead of looking at it under the light microscope or the confocal microscope, they look at it under the electron microscope, which really is much, much more, it gives you much more detail. So these things here, I don't know, my pointer's not working too great. No? Yeah. These asterisks here point to what we call collagen bundles. You can see this is much more magnified, and this is a collagen bundle, clearly, right? It's got all these tiny little, see, all these little dots are collagen fibers, and so this is very highly magnified. And then this kind of little ribbon that you see here, these are the cells, okay, right here. And you know, if you're used to looking at electron microscopy, you can see that's actually correct. These are cells. And they claim that these are the same cells that they saw with the other type of microscope. Now, in order to really prove that, there's another step they should have done, which they didn't do. They needed to do what's called immunoelectron microscopy, where they label these cells with gold particles, which you can actually see with the electron microscopy. It's a very, very difficult technique, but it can be done. And you can actually, you would have needed to actually confirm that this is the actual same cell that they saw with their other technique with the gold particles labeled, and they didn't do that. So they also use this image to say, look, this cell is only on one side. Well, again, you know, here, this white space, there's no saying that that was not just artifact. I mean, after having seen all the other images, you could argue that it's not, but I think this evidence is actually quite weak to ascertain that there's no cell on this side. I mean, it's possible, but this could have simply been sort of ripped. So anyway, that's the model they're putting together, and they're proposing that essentially they have a sponge, and that the sponge is lined with cells that have interesting properties. Okay. So, okay, now they said, well, so far, right, we've only talked about the common bile duct. So they went and they looked elsewhere. They looked, the next place they went and they looked at the skin. So here's a skin biopsy. And you can see the same kind of idea, this pink stuff, and you see all of these white things, which in the past people would have disregarded, right? And that they use the same technique, and it's not really clear to me how they actually did this. Did they apply their endoscope on the surface of the skin and look through the dermis? The epidermis and the dermis, I'm really not sure. They don't explain that. But anyway, they show this picture and they say, look, we saw the same thing in the skin and we saw the same CD34 staining. Okay. Then they went and they looked at, let's see. Then they went and looked at a whole bunch of other tissues. So, you know, bladder, esophagus, stomach, colon, lung, blah, blah. And they did the same CD34 staining, and you can see, I mean, you see kind of staining, and you see similar pattern. The interesting one here is fascia. And they don't explain where, what fascia, where, what part of the body, but you still see this, which is very interesting. So what is fascia? Fascia is something that I personally am very interested in. A lot of people in the world of manual therapies, for example, are very interested in fascia, because fascia is something that was something that was almost like forgotten, that people had not really been aware of the importance of these sort of sheets of connective tissue that connect, that separate the muscles, that go around the muscles. And now what they're basically saying is that these fascia structures, such as here, again, it's not the greatest picture, but they're in fact sponges themselves, and that they have the same kind of lining that the bile duct had. And so that's where this whole interstitium idea came, and they started saying, well, look, this is everywhere. This whole sponge structure is inside structures that in the past you would have thought were dense. So let me see. Oh, the other thing they did is they're pathologists. They're very interested in biopsies and cancer, right? And so they went back. This is a colon biopsy here, and they did what they call a tattoo, endoscopic tattoo, which is they inject this tiny little bit of ink right underneath the surface, and they wanted to see whether these interstitial kind of sponge-like structures had a connection with the lymphatics. Remember that there was that other lymphatic stain that they found in one place but not another? And so they saw that inside of this is the area of the sponge, and they see these little black things, and then these black dots of ink are taken up by macrophages, which is what you would expect. And then they saw a little bit later that they went to the lymph nodes. That's the draining lymph nodes. So that sort of suggested that, yes, indeed, there's this fluid that's sitting right below the surface of the mucosa drains into the lymphatics. Not a big surprise. I mean, that's what anybody would have would have thought, right? And this whole idea of pre-lymphatic is important, because the idea is lymphatic channels don't just start. I mean, they're actually collecting fluid from the tissues. That's what they do. So it would make sense that as lymphatics, it's almost like the branches of a tree. When you're able to see a lymphatic vessel, by the time it's big enough, it's probably like a big branch, right? That's when you see it. But then when it turns into the finer and finer and finer and finer branches in the tissue, well, it really turns into these vacuoles, these kind of sinuses, right, that collect fluid. And so it's just nobody had ever seen it this way before. But people knew they were there, you know. But it's nice that they were able to demonstrate it. So what they then started talking about is this sort of kind of universal body-wide structure, and I think that's why it turned into an organ. And the word organ, I think, was unfortunate, because a lot of people strongly disagreed with that. If you read some of the commentary that followed the article, you know, there's a lot of, you know, thumbs down. Should not have called this an organ. It's not appropriate. You could argue about this for a long time, but I'm not going to get into whether it was appropriate or not appropriate. It's just the important thing to realize is that the original article did not talk about an organ at all. It talked about an interstitium, which is exactly appropriate. So what is the role of the interstitial fluid-filled space? So again, I talked about that before. So mechanical forces could have an impact on it. Very important. It could be a pre-lymphatic, you know, between the tissue and the lymphatics. Yes, absolutely, agree with that. It could play a role in spreading, yeah, of pathogens and cancer cells, just like we saw the tattoo ink spreading and going to the lymph nodes. And so the idea is that this is a space that we should pay attention to. Could be important. Yeah. Is it a new organ? Is it new at all? So you could say, let's forget about whether it should or shouldn't be an organ. But what about the interstitium? What about the claim that it's new? Well, that's a problem. So I'm going to go back to my own research. So this is a paper that we published back in 2001, so almost 20 years ago, where and that's the other thing too, is that there was some speculation in the media about this could have something to do with acupuncture. Well, 20 years ago, we found that if you insert an acupuncture needle and then you rotate it, there's interesting things that happen. And acupuncturists have known this for thousands of years, that the tissue kind of winds around the needle. And what is this tissue? Well, guess what? It's the same tissue. So this is a picture that, you know, I published in 2002, my lab at UVM, University of Vermont. This is an ultrasound image of, so looking down on a piece of connective tissue from the surface, right? And this is the needle in the center. And you can see that this is the connective tissue as we're looking at it. And you can see all of these little dots here. And this is a much, much lower magnification. This little bar here represents 1 millimeter, whereas I'll show you, I'll compare the image for you later. The image that they took with their confocal microscope is much, much more magnified, but I think you can see the resemblance. It's very similar. So this type of structure, the interesting thing about it is look what happens when you rotate the acupuncture needle. The whole thing gets pulled and stretched. I mean, and there's your mechanical transduction, right? That's really quite, and you know, we described this 20 years ago. And so you can see how that if you had fluid inside of these little sponge holes, that it would get kind of just, you know, wrung out. And so that's one interesting aspect of it. But the other interesting aspect of it is the actual cells that are inside of this tissue respond. We know this. They respond to this mechanical stimulation by changing shape and expanding and releasing substances like ATP. I mean, we've sort of described a lot of what happens to these cells. Now, we never looked at CD34, which I'm very interested in, and we're definitely going to do that based on having read this paper. So it's definitely something that will be, you know, useful to add to the existing literature. No question about it. Just here, just to give you you see how these little white and dark holes. This had no stain, by the way. This is completely neat, you know, the ultrasound image. This had a stain, but still, I mean, you can see this is greatly, you know, this is a different magnification, but I think that I tried to eyeball it and actually see whether the magnification matched, and I think it's pretty good, actually. I think we're looking at very much the same thing. This is just this is from our paper, the histology image that shows you that you can actually do the same thing, do histology and look at the tissues and make the correspondence between the in vivo and the ex vivo. So this is a paper that was in 2012, I think, where we looked at the different ways that you can stretch this tissue. You can stretch it with an acupuncture needle, that I showed you, but you can also stretch it just by moving around. You see how all of these structures here are being pulled and pushed, and all of these sort of, these are the sponge thing, right? These are the little collagen fibers that make up the sponge. And this is how it all gets, you know, mechanically stimulated. And the interesting thing is, so what happens as a result of that? The other thing that the authors of the paper should not have overlooked is the very important work of people such as Dr. Melody Schwartz, who is, she's a MacArthur Fellow, so she has one of these sort of MacArthur grants, and she's at the University of Chicago, and for many, many, many years, she's been publishing about the importance of pre-lymphatics and lymphatic, you know, flow and from the tissue and the interstitium and everything. I mean, this is just an example of some of the very, very elaborate work that she does in immunology to show how mechanical forces play a role in funneling a lot of these sort of information that occurs in the tissues as a result of these very, very complicated and sophisticated immune responses that occur, and how immune information exchange goes back and forth between the tissues and the lymph node. This is her work. And unfortunately, this work was not cited in the paper of the new organ. There have been congresses on this. We've had, I think, 5 now so far, 4 or 5 fascia congresses. One of them was right here, organized by the Osher Center, where we had Dr. Schwartz as one of our speakers. And this was a very interesting, so the Fascia Research Congress has occurred, the very first Congress was right here at Harvard Medical School in 2007. And then since then, there's been every other third year. And this particular one was very, very interesting. This was 2 years ago, where it was a joint meeting of the Society for Acupuncture Research, the Society for Integrative Oncology, and the Fascia Research Society. I don't know if any of you were at this Congress, a few, but it was very interesting because we had basically experts from basic biology, people who were like interested in immunology and connective tissue and basic biology. And then we had integrative medicine, clinical people who treat patients with cancer. And it was all about revolving around cancer biology and treatment and integrative medicine. And it was just a, very, very interesting. And a lot of this conference talked about connective tissue. So going back to what we're doing in my lab right here at the Brigham, we're very interested in the interface between the musculoskeletal system and the immune system, because the musculoskeletal system, right, is we think about it as bones, muscles, ligaments, right? But of course, as you know by now, like connective tissue is very much part of that. Every time you move, every time you stretch, you're stretching your connective tissue, not just your muscles. Just happens to be that this connective tissue is the same tissue where a lot of, by now, right, a lot of these immune responses are taking place. They're not just floating around, they're in tissue. So that what can mechanical forces applied to musculoskeletal tissues influence immune process related to inflammation and cancer. So I was already scheduled to give this integrative medicine grand rounds in June. And so I'm going to be talking about that. I'm going to talk about the work of our lab now, some animal models that we have of inflammation and cancer. And so I'm not going to steal my thunder now, but just giving you a plug for that. So going back to these CD34 cells. So I feel like this is something that I think we're going to definitely look at. I think they could be very important, because, as I said, they can differentiate, but they can also be communication vehicles between, so mesenchymal, meaning they're mesenchymal origins, so they're sort of part of the whole musculoskeletal world, but they're also immune-binding molecules, right? So there's that connection between the musculoskeletal and the immune, right there in one protein. So I think this is a very important piece of the possible piece of the puzzle that we're going to be looking at. So why did this get missed before? I find this question really fascinating. This happens, right? Science, there are these, sometimes I call these black holes of knowledge that get lost. And connective tissue and fascia is one of them. It's my whole career, I've been baffled by this. When you do a PubMed search and you put in, and this is part of the whole thing about our search engines, everything depends on the terms that you use to search. And if you don't use the right term, you don't find what you could find if you used a different term. So if you use all of these search terms, musculoskeletal tissue, connective tissue, specialists. I spent a lot of time with librarians back when I was at University of Vermont, because we were trying to lobby for changing mesh trees, because so much depends on this in PubMed. And one of the big gaps is connective tissue. There are very few search terms that can get you to these. We were interested in fascia, loose areolar interfascial planes. These are the types of terms that I use in my world, in my papers. Very hard to get to them if you don't use the term. And interstitium is another one of those terms that kind of falls in between things. It's the nature of this, right? This is the tissues that's in between everything, and it so happens to be in between our search terms too. So it's not entirely surprising that the authors of the New Organ paper didn't find a lot of the relevant literature for their publication, and it's a shame, because they missed an opportunity to link their paper to a lot of very, to work. I just want to close by showing you a movie of this is something that's really making me think. So one of the things that we do in my lab is we're interested in, again, this fascia. So this is the thoracolumbar fascia in the back. And I'm going to play you a movie of somebody who's lying on this is a motorized table that people use in chiropractic care. But this time we're just using it for an experiment. So we're having the table flex back and forth. We have an ultrasound probe here, and we're looking at this fascia as it moves, as the person is bending back and forth. And you can see, hopefully, that there's a lot of movement inside the fascia. And what we were concerned in my lab is the movement in between the layers. You can see all these layers, they're slipping and sliding past one another. But now when I'm looking at this layer, at this movie, I'm starting to see other things now. Inside each of these layers, if you think of each of these layers being this sponge, not only are the layers going back and forth, but the sponges are being squeezed. So there's probably even more mechanical, movement and fluid flow within this than we even realized. So, thank you for the paper, this new interstitial paper for pointing this out. So that's it. I'm going to just opening it up for questions if you have any, and hope this was interesting. It was terrific. Questions? Yeah, please use the microphone.
I'm a physician and neurologist, and I've been coming here many times. And when I first met you, I was fascinated that there was someone who was dealing with fascia, because I had worked at the Marino Center in integrative medicine and in chronic pain. And fascia was one of those things, even in medical school when I was there, which was probably before you. It was just something that you peeled off when you did anatomy to get to the real meat.
Right.
Coming back to the last few months, I had severe neurogenic claudication from multiple lumbar stenoses, and wonderful Dr. White at the Beth Israel Hospital did the surgery. And the process of recovery after the surgery has been so fascinating for me, because I've worked a lot with complementary therapists who really emphasize this, what is being called interstitial tissue, but as you said, this has been known for hundreds of years, thousands of years perhaps, through the health of the lymphatic system, the ability for it to express toxins, that massage is not just a feel-good thing, but really you begin to loosen up all the things. So, and drinking enough water to enable those congealed channels to begin to be able to express and get out that stuff, because the lymphatic vessels do not have any valves or anything like that.
Actually, they do.
Oh, they do?
Enough. They do. So I didn't talk about that, but this flow can be directional. Of course, when there's pathology in the tissues, maybe that kind of breaks down. But yeah, the lymphatic vessels, interestingly enough, do have these little valves.
That I didn't know, but
yeah,
drinking a lot of water drives the lymphatic vessels.
Yeah, there's a lot to. I think you've said it very nicely. I think that the role of the lymphatic system within the connective tissue in healing of injuries is extremely important. I think we need to understand more about
even coming back to the final point that you made, was having body work done after the surgery changed the way that my body functioned. And there's beautiful drawing of the stretching of the fascia. I mean, I had multiple lumbar laminectomies on both sides, permanent L4, L5 radiculopathy on the left. So we're talking about quite significant neurological dysfunction. But boy, it feels so different.
It's great.
And it feels very smooth and quite different to the life when I was a physician working.
Well, thank you for your comments. I think this is very important. I think you're absolutely correct there. Yeah.
Has there been any study of yoga and how that affects the fascia and how that is interfacing with the immune responses? I'm just wondering about research on yoga.
Yeah. Well, we do some research in our lab on mice and rats, and we do what we call mouse yoga and rat yoga, and I'm going to talk about that. I'm going to talk about that in my talk in June. It's not really yoga, obviously. We really focus on the stretching that takes place during the yoga. There's many other components, of course, yoga that are more sort of mind-body related that you need to really do this in humans, although we're starting to get intrigued now by the role of stress and in these types of interventions. But I'm going to be talking about that in June, in my talk. Yes. Sit here.
So these fluid spaces are interesting. Does the fluid leave? Is there an exchange of fluid outside? I mean, what's the mechanism of, and when you stretch, does the fluid stay in those
Where
compartments?
does it go?
Does it leak out?
Oh.
And how do you replace it? And is there much known about the fluid exchange?
Very interesting. Well, there's work that I didn't mention of a gentleman named Rolf Reed, who is in Norway, who talked about the interstitium and that of being this kind of restrained sponge. So the fibroblasts that we're talking about, they actually hold on to the holes of the sponge, and they restrain it because if in the case of, say, for example, inflammation, fibroblasts can actually lose these connections and they let go, and the sponge actually swells a lot more than when it's under its resting normal state. And you know how when you injure yourself, the first thing that happens is edema, right? That's the first phase of the triple response. Rubor, dolor, calor, whatever. But first, fluid extravasation from the blood vessels, first thing that happens. And Dr. Reed's work is very beautiful about how this tissue is actually under negative pressure, and that there's an osmotic draw, because a lot of the collagens are actually lined by negatively charged glycoproteins, a lot of sugar molecules that have a lot of negative charges, and that attracts water, so that the movement of water in and out of this tissue is extremely complex and well regulated, and it has a lot to do. And so mechanical forces are just one of the things that regulates how much water is in this fluid. But the direction of the fluid is very interesting, because if indeed the lymphatics have valves, say, imagine you have a sponge and then there's like a little tube that comes out of the sponge, right, that connects to the sponge. You squeeze the sponge, well, the water is going to go to the tube. But if the tube doesn't have a valve in it, then as soon as you let go, it's going to go back into the tissue. If, however, the tube has a valve, then every time you squeeze, it'll go into the tube, and then it'll keep going, and there's also negative pressure from the diaphragm, right, causing negative pressure inside the chest. That's what drives venous return. So the lymphatic pressure, the pressure differential inside the lymphatics goes into the pressure differential inside the venous system, which then drives it to the heart. So, this whole thing is just obviously very well orchestrated in order for not leaving tissue to build up in fluid to build up in the tissues. Of course, in some pathological situations, lymphedema, for example, it breaks down. Fluid sits there, and then the tissues becomes fibrotic and laden with protein, and lymphedema is very obviously an important tissue condition to study if one wants to understand those dynamics. So it's very, very complicated. But a lot is known about it. It's not new.
Just two things. One is, I think the original hype of this was from the Daily Beast. I don't know if you
Is that what it was?
Because that came out on March 27th.
Yeah.
And somebody sent me this and was asking the same questions, like it's the largest organ we never knew we had.
Yeah.
That's the title. And the second is the CD34 positive interstitial cells have been described before. These really elongated cells that are involved in communication within the connective tissue, and they've been described as telocytes. And so I don't know if you've ever
Telocytes?
Telocytes.
And what?
Group in Romania, and so
I didn't know about
it's
this.
very well known, but they've published mainly about these cells. They produce these exosomes, and they're involved in cell-cell communication, only based on the EM microscopy. So
Really? Oh, I'll have to go look at that.
cells
Telocytes.
in communicating with muscles, nerves, and collagen.
Fascinating. Thank you. Well, I'll definitely go look for it. I mean, that's very...
CD34, but they're also c-KIT positive, CD.
Okay.
In this paper, they didn't describe c-KIT. They said they were negative. So I was curious about that, too.
Okay. That's great. I'll go look for that. Thank you. That's fantastic.
Let's see. One more quick comment.
This revelation of a new tissue, so to speak, reminds me of when I was in graduate school, which was a long time ago, and my advisor was looking at these. We were looking at DNA fragmentation and replication, and there were some fragments that were labeled as Kawasaki fragments, which were part of the DNA replication process. And my advisor, whose name was Herman, said if I had realized that this was real and not artifacts, they'd be called Herman fragments. It's like a lot of people have seen these, and nobody bothered to say, this is real, this is not an artifact.
Well, I'm glad for
Before.
Yes, this is a good comment. I think that, a lot of people can see something and just ignore it. And then the right, prepared mind can look at the same thing and see something important. And so I really don't want to dismiss what the authors of the paper did. They did something important. They looked at it and they said, wow, this is nobody's ever seen this before, which is, I think their images, especially the ones where they're in vivo microscopy, are definitely good and new, and they will raise the awareness of this tissue. I think they've done something good. And so, it takes a lot of observation to do science, and I think this was a good example of that.
I just wanted to say this has been such a fantastic discussion, and the questions, especially that bring it all together. I love the question about whether there's been yoga research, and there has been research showing that stretch and yoga and the mindfulness that goes with this changes how people move, changes how they feel. There's empirical observations by teachers, by patients who've received these therapies. But there's so many steps that are important in between that really need to be thought of carefully before the hype spins. And I think that this is really, one of your gifts is to be able to see things that other people haven't seen and to say this is really important to look at, but to look at carefully and methodically and not to jump to conclusions, but also to see those small things in the context of these larger visions. And I think that in some ways is integrative medicine, to see the whole but understand the pieces. And it's so fantastic that we have you at the helm to do this. And thank you. We asked her at 2:30 yesterday afternoon if she'd be willing to give a talk that she already had given somewhere else, and she's like, no, let me see if I could do something on this new paper. And so this just happened in the midst of her busy day. So I really want to thank you for shifting gears and putting so much thought into this. And also, this gives you a sense of what we're going to be seeing in June, which I've seen some of the other work that Helene's going to be talking around cancer and connective tissue. So I hope that you will come and tell your colleagues as well. Finally, so before moving on, I want to invite us all to thank Dr. Langevin for such a great talk.